Thank you for joining us for today's webinar, Breastfeeding and Medications Uncovered, Ask the Author Live, with Dr. Kaytlin Krutsch, co-author of Hale's Medications and Mother's Milk 2025-2026, and Infant Risk Center at Texas Tech University Health Sciences Center. Before we get started, I want to mention that this webinar is being recorded, and if you miss any portion of the presentation, you can find the video on www.springerpub.com 5 to 7 business days post-event. If you have any questions today, please type them into the Q&A box on your Zoom control panel. We will make sure to send them to Dr. Krutsch and the Infant Risk Center. Now, without further ado, we will turn the time over to Dr. Krutsch.
Okay, well, I'm so happy that everyone is here with us for National Breastfeeding Month here in the US. And it's been a busy month for us. I think especially for us moms, we've got kids going to school. I have a kindergartner. This is my younger kid that you can see here, but on the 2023 edition, we were just appreciating how we had my baby's face on that cover, and she just started kindergarten this week. So what a busy time. I want to talk just about some things that are changing and a lot of current events, and I don't want to take up a lot of time away from the questions that you submitted, but I just want to throw out there that AI and human milk and breastfeeding, there is a lot changing right now, and I'm really excited about the potential that they have here with using AI to tease out what is actually happening in this part of the body that no one has really quite, I think, spent the amount of time and attention on that we wish. And I think that AI is going to do a pretty good job of helping us catch up. So I'm really looking forward to what comes out on AI, and I've got some ideas for how to do that here at the Infant Risk Center. So hopefully, give me some time, and we will have some changes coming. I also want to mention that if you've heard about SSRIs and pregnancy and about how the FDA is they have this panel that I sat in on, and it was a really big swing. I feel like the pendulum is swinging right now. And if you've heard about that panel, I just wanted to throw out there that I haven't actually read this article itself yet, but there's a lot of contention in what's happening here. And I think that this is one of the good things about Hale's Medications and Mother's Milk and the Infant Risk Center is that regardless of what is happening at the FDA or the NIH, though we interact with NIH and FDA, everything that I do for them has been out of the kindness of our hearts here at the Infant Risk Center. They do not fund us, and so our opinions are our own. And they haven't really changed because the science hasn't changed. And so I just wanted to make that statement that, I know that people are having a lot of troubles with trust in science right now and trust in how to keep everybody safe. And, it's a hard time to be in science because, I don't know many people who get into research and science thinking that they have, that they're a bad character. You do this because you want to help, and everybody has a different opinion of how to help. So I think that's really all we're working out now. And then one more quick topic. This was published last week, and this is really fun. So this is rules of thumb for estimating drug levels in breast milk. How well do they work? And this has been a long time coming. And if you don't recognize any of the names on here, Cindy Young, I've actually never met her, and I really want to. Someday I'm going to run into this lady and tell her how much I love all the work that she's doing. But Phil Anderson over here is a friend, and he is the man that writes LectMed. So we have pretty regular correspondence, and this is really fun for me because what they did is they took the Hale's book and they were looking at some of the drugs that were in there that had milk plasma ratios and that had the kinetics that we look at, like the molecular weight and the protein binding and the pKa's. And they said, how well do these rules of thumb really work? And that's a really hard question to answer because you have to look at relative infant doses, milk plasma ratios. It depends on when you pull the milk plasma ratio out. It's not great. But what they ultimately were able to say is, above all else, protein binding. If you had high protein binding, these are the red dots in this graph. If you had high protein binding, then you have a really pretty low risk of the milk plasma ratio getting high. So there's a couple of outliers up here. I've talked to Phil about we're going to have a conversation about those. But down here you see if you have a high protein binding above 85%, you can be pretty confident that that's not really going to be in milk to a large degree. Now remember, milk plasma ratios are not great ways of determining if this is clinically safe because you can still have a higher concentration in milk than you do in plasma and it not be a problem because it's still a very low concentration. But I thought that this was really nice. The problem with looking at molecular weight alone is that might help you determine if there's going to be any passive diffusion, but you don't know about active transport. And so, I was talking to Phil about how I really detest this because I say, well, these are the rules that we use to estimate if drugs are going to transfer into milk whenever we don't have any data. But asterisks on the end of that, there could always be active transport that we don't know about. And I really don't like that. But there's also research happening on that end to find out more about transporters on those lactocytes to see if we can predict that too. So all in all, mostly what I want to say is things are changing and they're going to be changing fast. And I think that in the next 10 years, we're going to be looking at a lot of these things very differently. So I'm really excited about all the changes to come. They also looked at things like pKa, so basic drugs were more likely to get into milk. And log P is your, if it's water loving or lipid loving. And so the lipophilic drugs were more likely to get into milk. And so these are all things that we already kind of thought, like, yeah, that makes sense to us. So it worked, and they were able to use the Hale's data to do this type of research, which I think is just really cool. Okay, so thank you for indulging me for my announcements. Let's do some Q&As. And we always get a lot of questions about psych meds, and so I got a few that I thought were going to be really quicker to answer than others. So I just wanted to run through these real quick. So someone's confused about paroxetine. Is it not an option in pregnant or breastfeeding patients with depression? And on the lactation side, we're not worried about paroxetine at all. We have it as an L2. The thing is, with pregnancy, it depends on who you talk to. There were some discussions about how paroxetine, it's not preferred in pregnancy because of the risks of fetal malformations. And so we want to watch out because if you put a woman on paroxetine while she's breastfeeding, it might be fine while she's breastfeeding, but if she gets pregnant again, then you might have some more concerns. So that's mostly why people try and stay away from paroxetine. It's not really because it's a risk during lactation. And then, would it be wise to not choose aripiprazole, so that's Abilify, at childbearing age to possibly promote breastfeeding, which is very difficult or even impossible due to reduced milk production? So knowing that aripiprazole can decrease milk supply is a concern for us over here. And that was something that I feel like we've known about for probably maybe like 5 years now over here. We've heard that time and time again, it seems like. But the thing about aripiprazole is if you know and you are okay with the risk of reducing milk supply and you choose to use this drug, this is not usually a first-line drug. This is a drug where you've tried some other things and it's not working. And so at that point you say, okay, if you're going to try aripiprazole, I actually like it because you know the risk of reducing supply. And if you reduce supply, that actually reduces your infant exposure, which I don't love the infant exposure of aripiprazole. So if you had aripiprazole and had full milk supply, I would think it's more concerning than because we don't have the same amount of milk that the baby's getting. So that's better, actually. So as long as you know what you're getting yourself into, then it should be fine. They would, and then we have another person that would like to discuss mental health meds in terms of Wellbutrin and other antipsychotics. It says they know that they are usually level 3, so it's a maybe, but they're taught not to use them. And I'm surprised because I see people using them all the time. And, it depends kind of on the antipsychotic. There are drugs that there are more data on, like olanzapine and risperidone and quetiapine, I think, have a lot of data. But they're generally pretty good. The Wellbutrin, it's not my favorite because I see it used in doses way higher than what we see the studies in. And so, whenever we do that, then that's when I start thinking like, I'm not sure. It depends on the baby. So I feel like I see them used every day, but not necessarily for every patient. So you want to watch for polypharmacy, high doses, or if you have a vulnerable infant. Those are the things that make me kind of like increase my level of suspicion and say, maybe we should back off here. Not on the medications necessarily, but on how much milk the infant is getting exposed to. This is an interesting one. Is creatinine safe for breastfeeding mothers and babies? I've been hearing a lot about this lately, and it's kind of funny because my nurses tell me that we get these questions, and I'm like, really? Like creatinine? Like they're using it for weight training a lot. Like it's in a lot of these supplements that you use whenever you work out. But now there is, so this is something that was submitted with the question. It says the standard dose that has been recommended for weight training, but then also there's newer ideas for brain health. And there is some data to support creatinine as being protective for Alzheimer's. But the thing is, the dose for that is really high. So it's more like 20 milligrams a day. If you have like a lactating woman, that is not something that I would love, because if you have doses that are more than that 5 milligrams a day, you're going to have GI disturbances. And so that's not necessarily a milk problem as much as it is a person problem. Like I wouldn't want to do that. But and then they also just asked about pre and post workout supplements. So I have some more data to show you, or maybe not quite data, but creatinine, it's naturally in milk. It peaks about 2 weeks postpartum. We don't have data when you supplement it like this. So this is a protein thing, right? If you are low in protein in general, if you start increasing your protein level and you are deficient, then you'll make more milk. And so sometimes I hear people talking about that. But if you just are increasing one component, the creatinine, then that really isn't going to change how much protein there is. Or in dairy animals, at least, we know that if we increase creatinine or any other individual protein component, then we know that we don't alter nutrient composition very much. And thanks to my dairy friends for letting me know about that. What you can see is an increase in milk urea nitrogen, which is a byproduct of whenever you're processing the protein. And that's going to be well tolerated in most healthy infants. Even if they're preterm, I think they probably could handle that. But if you have impaired renal function or a really young baby, that might cause them to have some dehydration. And so watch out for that. And as far as the pre and post workouts, I think, there's so many different products on the market. You might be better off finding a product that just has creatinine if that's what you're looking for. These pre and post workouts, I can't say much about what's in a bunch of them. I know some of them have like ashwagandha and stuff like that too, I think. But a lot of them have a lot of caffeine, and they can have caffeine in really high amounts. So just watch for that dose of caffeine, and especially if you have a small baby. People have such different opinions on caffeine and if it actually bothers their baby or not. And so I think that's kind of an interesting, um, I don't want to say conundrum, but I think everybody has a different opinion on what they're willing to do. It's like, even myself, like I knew that there's not a whole lot of caffeine in milk, but does that mean that you want to drink a coffee? Do you want to risk it? If you've got a baby and you want to go to bed, I remember deciding maybe it just wasn't worth it a time or two whenever I was breastfeeding. Someone said, oh, in all caps, nonetheless, what's the latest information on breastfeeding and recreational drugs? And then we got another question about should we be discouraging mothers who ingest marijuana? What are the risks more than the benefits? And then vaping. I don't have any more information than I usually do, but I also, again, am really working on something. So for now, what's the latest? Nothing new. Uh, all of the guidelines, I know that ABM's guidelines on substance use disorder updated, I think it was in 2023 now. So it's still now, by now it's a couple years old, but it's more, I think, I don't know if permissive is the right word, but accepting, and maybe they're focusing on harm reduction rather than this statement about abstinence that I think that we are becoming more aware of, that just isn't working very well. So if you discourage moms to breastfeed whenever they're ingesting marijuana, this is a great question. I don't know that I have any good answers, but I'm working on it. So just stay tuned for that one. Also, if you are interested in chatting about cannabis and breastfeeding, any opinion really, like we're trying to get the entire range of opinions from yes, I don't think there's any problem at all to no, I would never expose my baby to that, and everything in between. It's kind of interesting. We don't have any problem getting people on the polls, but I'd like to talk to some more people in the middle that are like, I'm not really sure what to do here. So if you are interested in chatting about that, or if you have moms that you can share this with, they can fill out this form. And we are currently doing, it's not a research project, it is called customer discovery. So it's just like a 10-minute conversation. So if you wouldn't mind sharing that, that would be lovely. And okay, someone asked about codeine, which I thought was a really great question because the case report where the kicked a hornet's nest got retracted, and what are the current risks for evidence? And I was surprised. I thought that I had talked about this before, but I guess maybe I haven't. And this is the original case report. It was in the Lancet, so a really well-respected journal in 2006, and this actually kicked off an entire field of pharmacogenomics. So this getting retracted, this case report actually did not get retracted. So it got published in the same case got published in 3 different places. Lancet never took theirs off, but oh, I must have deleted. I think I deleted the slide. I'm so sorry. But there are 2 journals that it did retract. Oh, I think it's just ahead. We'll get there. So what happened after these case reports is that in 2017, the FDA announced that they had a lot of concerns about codeine and tramadol for breastfeeding moms, and they said that they could cause excessive sleepiness and serious breathing problems, including 1 death. And so they said that this was a really bad idea, and it could be this differences in metabolism between people. So that was the risk. And my friend Phil Anderson that I just talked about, he also did this review back in 2016 where they looked at all of the codeine case reports. And so this is the death that they were talking about, that Corinne article. And then there was another death about that had a combination of things, including codeine. We now know oxycodone's usually okay up to 60 milligrams. Butalbital, this is one of the reasons I don't love butalbital, and this is soma cariciprodol. But we do have, 2 deaths listed, even though this one is pretty questionable about how much it is the codeine versus the entire rest of the situation. So this is why they made that report. And then this is what I was talking about, how the 2 journals, Canadian Pharmacist Journal and Canadian Family Physician, they both retracted it because what they found out is whenever you go and talk to the toxicologists that were around in Toronto back when they were doing that case, is that they actually think it was an issue of direct codeine dosing to the neonate, and they actually found that out from I think the Tylenol levels. They said the Tylenol levels in the infant it was not possible to get to that level without directly dosing it to the infant. So they did retract these. So that's a really big deal. Lancet did not, and I think that has something probably to do with the implications for the entire pharmacogenetic community, because that's one of the cases that they have been built on. And then I just also did want to point out that this is the one that we were looking at that got retracted or not retracted technically in this case. But these publications are all from the same lab. And so that is, this is a little bit hard to talk about because, I really don't know what was done in good faith versus what wasn't. But these really over time have not panned out. We haven't seen them in other places, although that could be because everyone stopped using codeine and so you don't see the case reports anymore. But the final verdict from my perspective is that codeine is probably not really any more risky than any of the other opioids. Personally, I think that there are better drugs available than codeine to start with. So it's not my first choice to use, but I don't think that it's any worse than the others. We got a quick question on angiotensin receptor blockers and GLP-1s, and someone said there's a lack of data and no clear path, although intellectually it seems like they should be okay. And I do want to point out that valsartan, we actually do have data on because we did a study on a combination drug for heart failure a few years ago here at the Infant Breast Center, and we could not find any valsartan in it at all. So it was undetectable. So valsartan, I think, is a reasonable option in lactating women. Again, ACE inhibitors and angiotensin receptor blockers are things that are contraindicated during pregnancy, but you can use them in the first trimester. So as long as a mom has been counseled that if they get pregnant, they need to come off of these because they can cause fetal malformations, this is something that I think is an option. Also, semaglutide, I know we've announced it here before that we did the study on the injectables and found really low concentrations in milk. So I'm not so worried about that. I don't love the oral formulation because it has a permeation enhancer, which I think could mess up some other things that I just not my preference there. We did submit a new article on tirzepatide, and I think this is the first time that I'm announcing that. It was a smaller sample just because of the funding that we had to do that study. We used most of it on semaglutide, and then everyone started using tirzepatide. But it was pretty much the same story, which is there's just not very much of it in milk, which is exactly what we expected. So I hope that helps you. These are all L3s, I think, just because we're the only ones that have done the studies really on these, and I would want larger sample size before I move it to an L2. But I think that once we get confirmation from other people for doing similar studies, it'll get bumped to an L2. With these semaglutide and tirzepatide, I do want to just throw out the caveat that I like using these later in lactation, not really early in lactation, because you can change milk composition theoretically. And I wouldn't want most of the baby's nutrients to be coming from maternal milk while they're taking these things, because I mean, if you've seen people taking these, like they don't eat, and you need to eat if you are or you need to have a lot of nutrients and have a good diet. And this could be a very long, complicated conversation, but if the baby's already eating complementary foods, or perhaps they are doing some supplementation, then I think that they're in a pretty okay place to breastfeed while on those, as long as they can keep up milk supply, which is another reason to delay use. We're also working on an economic study right now. Oh, this is kind of fun. I don't think I've talked about this yet either. I'm doing an economic analysis with some economists where we're comparing semaglutide use to breastfeeding, just looking at the cardiovascular outcomes. And so far, what we're finding is this is what I want to call it in the end, is breastfeeding is the body's Ozempic. You get just about the same cardiovascular risk reduction with breastfeeding as you do with like 30 years of semaglutide. So how about that? So if you choose to breastfeed in the long run, I'm not speaking about weight here. I'm talking more about like um, blood pressure and myocardial infarctions, and I think we might have included diabetes in there. I can't remember, but we've got an abstract I think that we just submitted on that one. So hopefully more to come on that before too long. I got some questions about things like retinoids and Botox and those types of things. And I just wanted to let you know that on the Infant Risk website, we have been doing a series of things. We lovingly have dubbed this in the Infant Risk um, center here. We call this like our vanity articles. We've been trying to go through a lot of these topics that we get a lot of questions on, but I don't always have these kinds of things in the book usually. So I thought that I'd throw that out there. And that was it. So I think that I will, I've got, let's see, 5 minutes. I've got 5 minutes where I can go through and look at questions. Sorry, I'd hoped I'd have a little bit more time to do live questions. I think people liked that last time. And if you have any feedback about if you like the live questions versus the ones that I put up on the slides, let me know about that too. And maybe my friends at Springer can tell us a good way that they can get that feedback.
Sure. Thank you, Kaytlin. This has been great. This is Lee with Springer Publishing Company. We have over 15 questions in the Q&A box, but we also have a fair amount of things that have come in the chat. So it's up to you how you'd like to proceed. We can, if you'd like, I can read a couple of the questions from the Q&A, but if you'd rather, whatever works best for you.
If you have any primed and ready to go, feed them to me and I can see if it's something that I can answer off the top of my head.
Sure, sure. And just so everybody knows, we will go ahead and give all of the questions that people have put both in the chat and in the Q&A to Dr. Krutsch, and then that will help for a future event as well as any additional communications. So, okay. So here's one. Um, Marnie said, "What are your thoughts about as ashwagandha and
Oh no.
breastfeeding?" And if you want to answer it in the
Ashwagandha.
future, we can answer it in the future.
Oh,
Just say
I
the
don't think I'm
words.
gonna have any better answer in the future. That's see, these are it's like herbals. It's like they're the bane of my existence because I never have the answers that I want to have. And I've done a couple of lectures. I can't remember who it was for last year. Maybe it was Ilka, or maybe it was I think I did one for someone in Australia about why we don't have the same answers for herbals as we do for medications, and it's not because big pharma is sabotaging it. It's I think that we also have something on the Infant Risk webpage actually about ashwagandha. Um, I think we used it as the example of why I don't have answers. And the thing is, like, there's so much background research that has to go into these compounds before I can even do a lactation study. And for the herbals, like I think not ashwagandha, but kratom. For kratom, we use that as an example too because there's like 20 alkaloids in kratom. So if I were to do a lactation study, I would have to study 20 different compounds. So doing one kratom would be like doing 20 drugs, which is, more than what I can handle in a. But,
Perfect.
and then more than that, each natural product contains a different, like the different strains and the different products, and it's really hard. So I don't think I answered your question. I don't love ashwagandha in breastfeeding women, but they put it in everything these days.
That's great. Thank you. Well, thank you for that. And let me ask one more, if that's okay. Do you have any information research regarding supplement use, such as liquid gold or
Oh
fenugreek?
no.
I'm sorry again.
It's the
Safety
same
and
answer.
NICU babies.
It's the same answer. Oh, and I
Okay.
see somebody popping up. So not regulated enough is the issue. Um, that's one of the issues. I always, there are good players and bad players in here. And like sometimes you can find things online. Everything that the FDA recalls is because it got on the market and then it had something in there that it wasn't supposed to have, and then it comes off of the market. So that is an issue, but it's only one of the issues. The other things are what is the transfer into milk? I can't answer it. And what things should I even be looking at that could be causing harm? When you have a pharmaceutical product, it's just one thing for the most part. I mean, sometimes you'll have some metabolites, or you'll have like the Ribelsis, the oral semaglutide. I have to think about the permeation enhancer that they put in it, but it's it's just a whole different ball game whenever um, whenever I just don't always know what's in it. I saw another question about can we talk about what we know about Zurzuvae or zuranolone and possible effects on milk supply? I know whenever they did the clinical trials, so the FDA required them to do some clinical lactation trials, and whenever they did them, they didn't mention anything about the reduction on milk supply, but there was a little downward trend, but it's the same downward trend that I've seen on other drugs like brexanolone and then another one that hasn't been published yet. Um, and I just kind of chalked that up to the moms being separated from the infants. That doesn't mean that it doesn't decrease milk supply, but they all seem to be doing it about the same rate. So I just kind of thought that it probably wasn't, but that's as good as I've had there. And I'm happy to keep answering questions for a few more minutes while I'm here.
Sure, that would be great. All right, so we have, um, let's see.
Someone asked about lisdexamphetamine. We are
Yeah,
currently studying, so this is a stimulant used for ADHD, and we are currently studying the stimulants for ADHD because most of the data that we have for those are for illicit use and not prescribed, supervised use of the amphetamines. And so I don't have a great answer. To me, it depends on the baby and it depends on the dose. And if it's a healthy baby and a lower dose, I'm not so concerned about it. I always would like for the pediatrician to be aware so that if they have problems with weight gain, that's something that will be at the top of their mind. But other than that, once you get into more tricky situations, we just don't have enough data there.
right. Um, Here's another question that came through. Could semaglutide potentially help increase milk supply for a mom with PCOS, insulin resistance that is struggling with low milk supply?
Huh?
And would it be advisable to start taking again? Was taking pre-pregnancy. Mom
Okay.
believes Ozempic helped her get pregnant after many years of trying.
Yeah, we've been hearing that a lot. We call them Ozempic babies. I think for moms that have the PCOS, this is just pure speculation on my part. Um, I think that I would wait. I don't think that it would increase milk supply because I think it would take longer for you to reduce the weight, and that would increase milk supply eventually, probably. But I think in the meantime, you'd probably lose milk supply, possibly to the point where you could not breastfeed anymore. However, if you are pre-pregnancy, especially like if you had gestational diabetes, PCOS, and you want to be pregnant in the future, I think that now would be the time to use the semaglutide to reduce, um, the weight, and hopefully then whenever you are postpartum, you wouldn't. I think those are like estrogen issues with. I'm not sure if we actually know the answer to that. I'd have to look it up. Um, but preventing it on the front end, I think, would be better than trying to take care of it right now.
Right. And how about one more question? Do you have time for that?
Yeah, sure.
Awesome. So, Anya mentions our hospital has been increasing their BP medications. For example, Procardia XL 60 megs BID. The Hales book states Procardia XL 30 megs BID. Some of those doses are being given to moms with NICU babies. Also, some
Mm-hmm.
people have also been put on high doses of labetalol with and without procardia. Was just curious what your thoughts are on those higher doses of BP medications.
Yes, and Lee, thank you for being a good sport. So Procardia is nifedipine, and labetalol is the second one, and yeah, we see that a lot. And that's kind of one of the reasons why we started looking at other antihypertensives here is to give people more options because they used to say no, we would never use an ACE inhibitor in these moms, and my co-director here at the Infant Risk Center is an OB, and I've asked her before, saying why would if we're looking at labetalol, why would I see a mom on 2,000 milligrams of labetalol a day? Like that seems like a really bad idea. And she just said, if it's not working and you don't have anything else to do, you just use more. Like that's the alternative is waiting for them to have a stroke, and that's horrifying. Um, so as far as breastfeeding goes, um, we hear about a lot of these cases. I'm afraid of the ones that we don't hear about because I think a lot of times they're just letting them breastfeed. And here we try and say, okay, if you are using one of those really, really high doses, I like it better when the baby is in the NICU because they get monitored. And so I can be a little more aggressive whenever they're in the NICU and you know that if you push it, you're gonna know. I actually even doing that, I've never had any feedback saying that the babies have issues, but that doesn't mean I feel real comfortable about it. So what I usually do is like with the Procardia and the labetalol, I kind of think, okay, well, what's the highest doses that we've ever studied? And what kind of ratio of mom's milk to donor milk can we do to get closer in that range? You don't ever know whenever with the way that transport works and if there was transport and it was saturated, then you could go from a low level to a high level. And then so if you then say, okay, well, I'm going to use half of that and expect it to be the same, I mean, that's a risk. It's a risk that you just don't know what's happening at those high doses. But I still think that the benefit of the breast milk, you can't deny it. And so what we try and do is come up with a ratio. And so kind of what I tell the nurses over here as I don't want to say rule of thumb because Dr. Hale used to always hate it. Whenever we said rule of thumb, he said someone came up to him and told him the origin of where that comes from. But the general rule of what we've done just with the experience is okay, if they're on a lot of medicine and they are on really high doses, it's like I don't know that we've ever come across a scenario where if you just started out with a ratio of like 1 part mom's own milk to like 4 or 5 parts donor milk, and see if the baby can tolerate it. And they almost always tolerate it really well. And so then from there, you can kind of titrate up a little bit every day. So we usually say like 20% a day is what I like to do. Um, and I haven't had any feedback of problems with that. So that's the best that I can give you for now.
That's great. That's great. Thank you so much. If we can just go to the slide with the Hales, I think it's the last slide in the
Okay,
presentation.
yes, I'll have to find my slides again. Hold on.
Um, but thank you, Dr. Krutsch, for an excellent and informative presentation. And we want to thank everybody who spent the time with us today. We wanted to let you know a couple things. One, if you're interested in purchasing the print book, Hale's Medications and Mother's Milk 2025-2026, you can receive a 25% discount using the code webinar25 at checkout on www.springerpub.com. And more importantly, for any bulk purchases or multi-user subscriptions to halesmeds.com, our colleague Susan McElwain, S. McElwain at springerpub.com, will follow up with all of you who've registered and attended today within 5 to 7 business days with information about how you can purchase either bulk purchases of the print book or a multi-user subscriber. She will also provide you with information about individual subscription that you can purchase through halesmeds.com, because we know a lot of you love to have that subscription as well. As a reminder, the recorded session will be available on springerpub.com within 5 to 7 business days. And we want to thank you again. Thank you, Dr. Krutsch, but thank you, everyone, for taking the time today. And we want to wish everyone a great afternoon. And we look forward to you joining us for future Springer Publishing webinars. Thanks again. Oh, and we'll share all your questions and chat information with Dr. Krutsch as well. So thank you again. Thanks, Dr. Krutsch, and have a wonderful day.